Right. So next we will have Dr. Mahesh Bharathi. He has to go for another session also. So we'll just have him talk about just GATT to do it. So GATT is, go ahead Mahesh. GATT is what?
Gonioscopy assisted transluminal trabeculotomy. The idea was to cover all the smaller procedures first and then go ahead with a 360 procedure. But then I have to go for the OPL session next. So I'll be talking about what, why, and when. As Dr. John already said, it's a minimally invasive glaucoma surgery, minimal trauma to the target tissues, faster operating time, modest efficacy, high safety profile, and rapid recovery. This is the glaucoma armamentarium that we have along with us as of now. The traditional glaucoma surgeries on the right hand side and the micro-invasive glaucoma surgeries on the left hand side. And I will be talking about the GATT procedure, which comes in the excising or cleaving the trabecular meshwork. Developed by Dr. Grover and his team at the Glaucoma Associates of Texas, it's a non-bleb forming MIGS procedure, conjunctiva sparing, it's an ab interno, and 360-degree trabeculotomy. That's a major advantage, that it achieves a complete 360-degree cleavage, and it can be done either by an illuminated catheter or a suture based, where we use a 50 Prolene suture. So this is the microscope rotation, and so we mark the microscope, we trying to achieve a 30 to 45 degree bend of the microscope head, and we mark it so that when the two pointers coincide, we know that it is 30 degrees. So that you don't have to mark it every time. You mark it and keep it, and every time you do it, it's aligned. And then there are specific apps which are available. This is for the iOS, which is the measure app, which can measure the 45 degree angle. You have same for the Android also. A few tips to identify the trap meshwork. Nothing beats like a preoperative gonioscopy in your OPD. You don't want to have any surprises. So you should be very thorough with your preoperative gonioscopy at the OPD. And then one is by looking at the pigmentation, moderate to heavy pigmentation, especially in PXF and pigment dispersion syndromes. You will not have any difficulty in localizing the trap meshwork. But if it is not, if it's a lightly pigmented trap meshwork, you can use trypan blue to stain the trap meshwork. It stains beautifully, and you can visualize the trap meshwork. And then you can actually do something called as a provocative gonioscopy, or you can put the patient in a reverse Trendelenburg position and make the blood flow towards the head and see the blood in the Schlemm's canal and visualize the trap meshwork. Patient selection is pretty same for any of the MIGS procedure. Like the indications are for primary and secondary open angle glaucoma. You can do it around either standalone or with a cataract extraction. Better to start with controlled intraocular pressures, at least on 2 medications. To start with, do for mild to moderate disease patients. Absolute must is a pre-op gonioscopy, and practice few sessions of intra-op gonioscopy in your routine cataract cases. So this is a routine cataract case. At the end of the surgery, you put your gonio lens, visualize the angle, see the trap meshwork. See the Schlemm's canal, that is the blood in the Schlemm's canal, you can visualize that. And below that, you have the trap meshwork. So take your Sinskey hook, go there, and just touch it and see. That will help your hand-eye coordination. Before you actually do your MIGS procedure, practice this. Now that's a movement that we are going to do for a KDB glide. We mark it and move it ahead. So that you can practice it before even you start your surgery. You can do it in your routine cataract cases. Now, whether to do it in combination or with a standalone cataract extraction, you have to explain the consent, detailed consent, because patient will be expecting a faster recovery in a cataract surgery. But because you are doing a MIGS procedure, especially with GATT, you can expect a lot of hyphema, and the recovery may not be as smooth what a patient expects after a cataract surgery. Though the hyphema will clear in a week's time, you have to explain it to the patient that your clarity of vision will take some time. And when you do a standalone procedure in a phakic patient, you will have to use pilocarpine in the anterior chamber to constrict the pupil. That will help open up the angle and improve your visualization, and also prevent the anterior lens capsule from any inadvertent trauma while you are manipulating inside the eye. And which to do first, they have done actually a RCT and compared whether do it first or after the phacoemulsification, and there is no differences. When I do it before the surgery, just after making the rexes, so that during the surgery, if at all higher grades of cataract, you get corneal edema that will impair your visualization of the angle when you do it after the cataract surgery. So this is about the positioning. We said patient's head tilted away, the microscope tilted towards you, and as compared to a phacoemulsification where you do a bimanual procedure, both the hands are working inside the eye. Here you should have a good hand-eye coordination because your one hand is going to hold the gonio lens, which will be outside the eye, and the other hand will be manipulating the instruments inside the eye. And you don't want to put any pressure with your left hand or your right hand holding the gonio lens onto the cornea, which will create folds on the cornea and again impair your visualization. That is the major difference that you work with. And also one more thing is, if you are not in a comfortable position or your instrument does not allow you to bend the microscope, like John said, you might be sitting at a lower level to watch the angle, and that would be also again discomfort. This is a major cluster of instruments, that is what we use it for trabeculectomy, and then you just compare it with the instruments that we have for MIGS. We don't have major instrument, especially for GATT procedure. All that you need is a Grishaber forceps, a gonio lens, and this humble 50 proline. So we use a normal cautery. You have to make the mushroom tip of the suture so that it does not hurt your trap meshwork. Now you can, when you compare it with the mushrooming tip, you can see that there are two types of mushrooms available here. One is a small mushroom and one is a bigger mushroom. We don't want to have a bigger mushroom because that will not go into the Schlemm's canal. You just need to make a very tiny mushroom which is sufficient enough not to cause trauma to the trap meshwork. So wound construction, we have to avoid the limbal vasculature because we don't want any bleeding onto the corneal surface that is going to mix with your viscoelastics that you are going to put on the corneal surface and remain there and impair your visualization. A 2.2 keratome incision is more than enough. A temporal incision is what we use for a cataract surgery, and the same incision can be used to approach the nasal angle, which is where we start our GATT procedure. About this tangential entry for suture entry, I will explain it when the video comes. So this is what I was telling about the tangential entry. So when we introduce a tangential entry like this, the suture comes to the nasal angle directly like this. Suppose assume you make an incision straight here and the suture comes here in the center of the eye. We have to take the suture from here to the nasal angle, and that will create a kink in the suture. And the kink in the suture will not allow the suture to pass very easily through the trap meshwork 360 degree. So we make an approach nasally towards the tangentially towards the nasal angle that will help the suture reach the nasal angle in an angle so that it traverses easily. Then once the suture is introduced, you visualize the angle and make a goniotomy. This is a well-made incisional goniotomy. You could see the posterior Schlemm's canal. The roof of the Schlemm's canal has been de-roofed. And then we pass the suture. Once the suture passes around 180 degree, you will get a slight resistance. You have to overcome that resistance and keep passing it. It takes around 25 to 30 single passes for the suture to travel the whole 360 degree and emerge out from the incision. And the first time that it emerges out, it's a wow time. You will have a goosebump feel. And then once it's out, you just have to pull it the outside with a McPherson and the inside with the Grishaber forceps and achieve a 360 degree trabeculotomy. And this is an intra-op surety that your procedure has been really successful. Can you see this whole area getting completely blanched out? That means that whole angle where that collector channels are there, they have been opened out, and that is letting your fluid go, and you have achieved a trabeculotomy. This is a case of post VR surgery glaucoma with silicone oil bubbles, unfit for trabeculectomy, planned for GDD, but then had an intra-op gonioscopy and the angle was completely fine. So we went ahead and did a 360 degree goniotomy. This is at the end of 6 months. You can see a nice cleft, all 360 degree, the cleft has been seen inferiorly also. And this patient maintains an intraocular pressure of 14 millimeters on single AGM for almost 2 years follow-up now. So advantages is achieves a 360-degree trabeculotomy. It's very cost effective as compared to any other MIGS procedures that we have at present. It's conjunctiva sparing. Learning curve is there. It's steep, but it's short. Take clinic message would be patient selection is the key. Intra-op gonioscopy plays a major role. Avoid limbal blood vessels. Tangential stab entry into the cornea to access the nasal angle. And finally, practice, practice, and practice. All this presentation that have been made is being published in the TNOA's guest appearance of guest article, and you can go through it. Thank you.